Good morning, everyone, or at least this morning here in Milan. And I'm really sorry that I missed this great meeting there in Denver, but thanks to the technical skills of LivaNova that I must absolutely acknowledge, we were able to record this video that I'm happy to present to you all. So in the next 20 minutes, I will try to do some kind of journey through everything that finally led to the concept of the goal-directed perfusion and the result of this recently completed randomized control study. I always start with this slide because it was more than 20 years ago when we first noticed an interesting association between the nadir hematocrit on CPB and the risk of developing a severe renal dysfunction. This is an old-fashioned slide, as you can see, but this is a logistic regression association between hemodilution and renal risk. And after this first finding, the concept became more and more validated, and 10 years after, this American study actually confirmed that there is an association between the lowest hematocrit on CPB and acute kidney injury. And so hemodilution is bad. And hemodilution is not bad just for kidney, it's bad for the number of organs, because whenever the oxygen delivery and the oxygen content decrease, the organs inevitably will start suffering. But there's not just a problem with oxygen. There are other side problems. This is a very recent study that we published looking at the relationship between hemodilution and the coagulation system using a huge amount of thromboelastographic data. What we could see is that if we divide the patient population according to the hemodilution degree, that could be low or moderate or severe, and this is the delta hematocrit between the baseline and the nadir on CPB, then what we could find is that if you go above a certain degree of hemodilution, then blood loss will start increasing. And this is basically due to a decrease in the clot firmness. So there is dilution and probably even consumption of coagulation factors. And so this, in severe hemodilution, is leading to a higher degree of poor clot firmness and to a higher degree of transfusions. Then we start analyzing another concept because, of course, hemodilution pertains to oxygen content, but what is important for the organs is the oxygen delivery. That is, as you all know, the product of the cardiac output times the oxygen content, or if you are on CPB, the pump flow times the oxygen content. And so another 10 years passed, we are in 2005, and we could analyze not just the hematocrit, but even the lowest DO2 on CPB. And we could confirm that both are determinants of acute kidney injury, but the most important association was with the DO2. And with adequate statistical tools, we could identify a cutoff level that is around 270 milliliters per minute per square meters. And those who are treated with a low oxygen delivery below this threshold, they inevitably have a higher rate of renal replacement, even independently from the level of hematocrit. So another 5-6 years, we tested this association in an external series. These are data coming from UK and Belgium, so nothing to do with our institutional data. And these authors, again, could find the association. Again, the cutoff level was more or less close to the one that we previously identified. And we even introduced another marker that I will address later on, that is the ratio between the DO2 and the VCO2, the CO2 production. And again, those who were treated below the cutoff level had 4 or 5 times higher rate of acute kidney injury. And the same was for the relationship between the DO2 and the VCO2. So if we go to the present era, this is 2015, this concept is now very well established. And there are other studies in different places that again could confirm that patients with an acute kidney injury, they actually had a significantly lower oxygen delivery. And interestingly enough, the SVO2 did not differ between the two groups, so it's not a sensitive marker of the renal risk. And there are guidelines, there are consensus studies, consensus manuscripts, where intraoperative strategies that include minimization of hemodilution and maximization of oxygen delivery are suggested for the prevention of acute kidney injury. So the combination of a number of metabolic parameters is the guide for the goal-directed perfusion. This can seem quite complex, but actually the main point is that we know that there is a critical DO2, and whenever the patient goes into this region, he will start contracting an oxygen debt. And of course, lactate will start raising up, and the VCO2 will start raising up, SVO2 will continuously decrease, and the concept of GDP, we want the patient here. And we can check this with a number of different variables, but the marker is that we don't want the patient to develop an oxygen debt. So there are basically two goals in the GDP. The first one is a general rule. The general rule means that we should target the perfusion on the DO2 at a level higher than 272, and not just on body surface area and on temperature. And to achieve this goal, the important thing is the combination of the hemoglobin and the pump flow, oxygen content, oxygen transfer. To do this, the best thing to do is prevention. Limit hemodilution, hemoglobin will stay high, and goal-directed perfusion will flow out as a natural thing. But if it is low, then we should increase the pump flow. And keep in mind, it's quite easy. If you have an hematocrit of 24% and you have a pump flow of 2.4, then you stay exactly around 270. But whenever the hematocrit is going down, then you must increase the pump flow. Could be 2.8, 3 liters per minute per square meters. Transfusions are not the easy answer because we don't know exactly what is the oxygen carrying ability of the transfused pectoral red cells. And so we should follow the transfusion way only when there are severe signs of an increased oxygen extraction. So SVO2 below 68, oxygen extraction rate higher than 40%. So these are general rules, but the second, and maybe one of the most important goals, is individualizing the perfusion. So this means that we don't have just to look at what we are giving to the patient, we should look at what that individual patient is giving back to us as an information of the adequacy of perfusion. And here it comes the VCO2. CO2 is coming from the patient. DO2 is something that we are giving him. VCO2 is something that he is producing. Of course, we can act on DO2 only, but VCO2 is a signal. So this level is a mean value, but could be even too much or enough for many patients, but could even be low for some specific patient. So VCO2 is providing an individual response to the perfusion. That's why we summarize this in this quite popular 5 GDP laws. And the first one is the easy one, limit hemodilution, because every time you go below some levels of hematocrit, then the renal risk will raise up. And we have the tools now, an online tool to actually follow the 5 GDP rules. And this is the classic connect screen, and you have a number of variables, and of course you have the hematocrit on board. And this one is not that good. I mean, from my perspective, 22 start being a quite low hematocrit on CPB. But here it comes the second GDP low. That means maintain the DO2 higher than 270. And to do this, the right way is increase the pump flow. Here we have a normal DO2, and this is achieved increasing the pump flow. That is a third GDP low. We could achieve this one despite low hematocrit level by increasing the pump flow up to 5.7 liters. The fourth rule is, again, rely on oxygen extraction indices to decide whether or not you should transfuse this patient. And so going back to the same example, do we need transfusions here? No, we don't, because actually we have 70% SVO2, that is more than enough. So no transfusion in this case. And finally, the VCO2. VCO2 is strongly correlated with lactate production, and we will see later on why this happens. And actually, we can measure continuously this number and this relationship. DO2, VCO2 should stay higher than 5 or 6. We will see this later on. This is a good number. And so we are sure that that individual patient is doing well. And this is how it works. You see here this 77 minutes on CPB, and we have all the parameters on board. We have the history of the patient. We can record everything. We can reanalyze the data later on. We are at the end of CPB now. This is the DO2. You see how it decreased when the surgeon asked to go down with the pump flow for releasing the aortic close clamp, and then immediately went higher on. And so, again, in the present era, more and more studies are clearly demonstrating associations between acute kidney injury and DO2. This is a brand new one published in March 2017, and the Magruder's group, they actually compare goal-directed perfusion with conventional perfusion. And the basics of what they consider a goal-directed perfusion are minimize CPB circuit volume, that is the first GDP low, and maintain a DO2 higher than 300, that is second and third GDP low. By doing this, and by comparing this group with a control group, with a propensity matching, what they could find was actually that the main difference between the two was the nadir DO2. And the important thing is that if you look at the hemoglobin was exactly the same. So the difference was the pump flow, 1.9 to 0.4, producing totally different levels of oxygen delivery, and finally producing 8% of incidence of acute kidney injury versus 21 in the control group, 2.5 higher in the control group. So at that stage, what we had was a very sound information that there is an association between the low DO2 and the risk of acute kidney injury. But this is not enough, at least not from my perspective. From my perspective, we did not know that if we intentionally avoid low levels of DO2, if we apply the GDP, we can actually change the renal risk. To demonstrate this, we needed randomized controlled trials. It's not an easy trial. We needed support, and LivaNova provided an external support to this randomized multicenter controlled trial, the GIFT trial. This study was basically a pragmatic randomized controlled trial. We did not change that much. The thing that we wanted to change was goal-directed perfusion versus conventional perfusion. So we could enroll 9, 10 institutions in Europe, USA, New Zealand, Australia, and the entry criteria were very simple. I mean, adult patient, no severe renal dysfunction before surgery, and an expected CPB duration longer than 90 minutes. We did exclude patients treated with hypothermia. We accepted down to 32 degrees. And the primary endpoints were the rate of postoperative acute kidney injury, divided into stage 1, stage 2, or renal replacement therapy requirement. Then we look even at secondary outcomes, knowing very well that we were lacking the statistical power to address outcomes like mortality, but we did collect this data. This was the experimental hypothesis that the GDP would result in a 40% reduction in the acute kidney injury rate. The difference between the two was basically just the perfusion, targeted on a DO2 higher than 280 in the GDP arm and based on the BSA and temperature in the control arm, and the transfusion that were triggered by the hematocrit according to local standards in the control arm and were triggered by hematocrit plus sign of increased oxygen extraction in the GDP arm. We measured the nadir DO2 that was considered the one that was maintained for at least 10 consecutive minutes, and we did measure even the VCO2 related variables. These are the institutions which participated into the GIFT trial, and this is the respective contribution when we arrived at 350. 350 was 50% of the predicted enrollment rate of 700 patients, but according to our protocol, we had an interim analysis at 50%, and this is what I'm presenting you. This is a classic flow chart. We could, at the end of the day, compare 156 patients in the GDP arm and 170 patients in the control arm. And the two groups were very well matched. No huge differences in terms of preoperative and intraoperative risk factors. An important point is that if you look at the Euro score, then you see that it was quite low in both groups. It was around 2 to 3% risk of mortality. So it was actually a low-risk patient population. And these are the results. Acute kidney injury stage 1 was 11.5% in the GDPR, 22% in the control arm, with a statistically significant difference at the level of P0.01. We could not see differences in acute kidney injury stage 2. We did confirm the differences if we combine stage 1 and stage 2, and we did not see, we just saw a trend towards differences in any kind of creatinine increase. Secondary outcomes, as predictable, were not significantly different between the two groups due to the low power of the study for this kind of clinical outcomes. If you remember, the entry criterion was an expected CPB duration longer than 90 minutes. But this was not a withdrawal criterion. We maintained into the analysis that was an intention to treat analysis, even the patient with a very short or even a very long pump run. But we decided to do a sub-analysis looking actually at this segment of population. Those with a pump run longer than 90 minutes, but no longer than 180. So we excluded all the patients with a very short pump run, and we excluded those with a very long pump run. Looking at this subpopulation that was actually very well represented, the differences are even more pronounced. Here we are at 0.004. Here we are at 0.017, and we could even observe significant difference in the rate of patient with any kind of creatinine increase. So according to the protocol, we stopped the study for superiority of the GDPR. If we look at the GIFT trial in the context of the existing studies on GDP, it's very nice and interesting to see that all the studies are in the same direction. This is the Magruder study, propensity adjusted. You see that it's absolutely similar as a result to the GIFT study, and if we even include more ancient studies, starting with the first one that we did in 2006, whatever is the definition of acute kidney injury, this was stage 3 renal replacement therapy. This is any kind. This is any kind. This is stage 1. Whatever is the definition, then you see that the difference in favor of the GDP is always around from 2 to 2.8 as an odds ratio. This means that actually GDP patients have 50% less or even more of the risk of having any kind of acute kidney injury. That's an enormous amount of data coming from these studies that we are still analyzing, that we will publish in the next years. Basically, all these metabolic parameters were collected. And if we look at this, we have a number of additional information. The DO2 has some kind of association even with the ICU stay. If you look at this, there's no one. This is very long ICU stay. Nobody with a nadir DO2 higher than 280 enter this dangerous area. This is 20 days of ICU stay. If you look at the metabolic signs of contracting an oxygen dead means that actually you are producing lactase. Well, the SVO2 has nothing to do with the oxygen death. There is no association between the SVO2 and the peak lactase. And even if you look at the VCO2, there is no association at all. But when we go through the DO2 VCO2 ratio, things are changing a lot. Here you see the magic number is 5, but if you look at 6, that is more or less in the same range, then you see that there is an association between this ratio and the peak lactate formation, and basically hyperlactatemia that is defined as lactate level higher than 3 millimoles per liters. There's no one above this number who is developing hyperlactatemia. So it's a strong negative predictive value for hyperlactatemia. So why the DO2 VCO2 ratio is related to hyperlactatemia and the VCO2 is not? Well, it's a complex physiology, but I would summarize in this way. CO2 is coming basically from 2 different pathways. One is the mitochondrial one. This is CO2 produced through the aerobic metabolism. The metabolic needs increase and you will consume more oxygen, you will deliver more oxygen, and you will produce more CO2. This is the good CO2. But there is CO2 coming from buffering of the lactase whenever you are contracting an oxygen debt, and this is the bad CO2. And if you go through the basic physiology, if you have, here you have a normal human being, then suppose that you start producing an effort, you start running. So you have an aerobic energy production area, you run, you are in the aerobic zone, so you will increase the DO2 and you will increase the CO2 as well in a parallel way. So the DO2 VCO2 ratio will stay higher than 5 or 6. But if you run very, very fast, then you will contract an oxygen debt. And here you are, you will have hyperlactatemia and this ratio will decrease. And our patient, whenever he is contracting an oxygen debt, is here. It's like an athlete that is running too fast, hyperlactatemia, and reduced DO2 VCO2 ratio, because here and here we have the bad CO2 production. So in conclusion, the final sub-analysis that we did with the GIFT trial, if you remember, these were low-risk patients. We concentrate on the minority of high-risk patients that we had. And we look even at the number of clinically relevant outcomes. And you see that practically everything is in favor of the GDP, even with some significant difference. So probably, if we could concentrate more on the high-risk patients, we will see more relevant, clinically relevant differences. And so that's why I would anticipate that what we would like to do in the future is the GIFT-2 focused on the high-risk patient population. So having said this, I would like to thank everyone for the attention, and I'm sorry that I'm not in the position of answering the possible question to my speech. So thank you again, and see you soon.